Dr. Fox, in your testimony, you referred to a report that found that the number of independently owned physician practices has declined over 48.5% from 2018 to 2026. Do you agree with Dr. Snyder that the current structure of physician fee schedule is driving independent doctors to sell out to bigger consolidated entities, which drives up costs for everyone? And assuming your answer is yes, would you please explain? And if you could pull that mic just a little bit closer to you, I was having some difficulty hearing you in your opening.
Thank you, Mr. Chair. And yes, I do agree. Thank you for the question. And I think the problem is even bigger than that. A generation ago, 75% of physicians were owners in their own practices, and perhaps 25% were employed by larger health entities or corporations. And today it's just the opposite. And if I had to point to one thing that has led to the deterioration of independent practice, it is the lack of positive updates and predictability in the fee schedule. You can imagine that in addition to me taking care of, or our practice taking care of thousands of patients, I'm also a small business owner. And the costs of being a small business owner go up every single year. Rents, cost of living increases, the cost of insurance, and so forth. And without stable and predictable updates from Medicare, you can imagine how hard it might be to sustain such a business. Hence, many practices selling to private equity companies or being absorbed by their local healthcare centers.
Thank you. Dr. Smotherman, can you explain why the current fee schedule budget neutrality requirements pit specialties against each other and could cause unfair cuts for certain specialties if they project the reimbursement wrong for new codes?
Yes, so the current budget neutrality requirement basically pits different specialties against one another. So in order for one specialty to have an increased cost, it means an increased reimbursement, it means another needs to go down.
Can you give us a real-life example of that?
Sure. Pretty recently, there was an increase in the E&M codes, which certainly was warranted for physicians who see patients in offices like all of my colleagues. But the conversion factor had to go down in order to account for that in the fee system. So basically all of the other specialties, including radiology, took a pay cut in order to accomplish that.
All right, thank you. Dr. Mastashari, I'm never going to get it right, but
Farzad is fine.
all right. Talk some more about your suggestions on the advanced alternative payment models. You
Yes.
started on that in your opening, but I'm going to give you about a minute and a half to do that, and then
Yes.
I'm going to yield back.
The fundamental flaw in terms of the structure of the AAPM, I think it's very important for both signaling and incentives to have an AAPM bonus or reward program, but the fundamental structure of it currently is flawed in two ways. First, the payments kick in 2 years after you make a decision to join an AAPM. That is kind of not a great way from a behavioral economics point of view to have an impact. We would much prefer, and we talk to thousands of practices who join and those who don't join, and what I can tell you is if they signed up and they got immediately that equivalent of that AAPM bonus in payments in January in a one-time per person bonus, that would allow them to invest in all the kinds of resources that Dr. Furr talked about to be able to do the value-based care and to create an immediate incentive. The second flaw, as I alluded to here, is a percent of billing is not the best way to have essentially a site-neutral impact. The primary care physicians who are the lowest paid would then therefore get the lowest incentive to participate. So we would strongly recommend also turning it into a site-neutral per person bonus for any new patient who has not been in an ACO before, has not been in an AAPM before. That way you would encourage both more practices to join AAPMs, but also existing AAPM practices to reach out to patients in their communities and bring them into their ACOs.